Myocardial infarction, or infarction in general, is defined as an area of ischemic necrosis caused by occlusion of the vascular supply to the affected tissue. And the most frequent one, the myocardial infarction, or also abbreviated as MI, is most frequently because of the just said process, the occlusion of the left coronary artery, the LCA, and the left anterior descending artery, the LAD. What are the risk factors? What predisposes us to this? First of all, we see gender is a major role, meaning males are more common, the age, usually over 65 years old, and the main one being atherosclerosis, which, as we already talked about, is a plaque buildup in the vessel, and if that is unstable and bursts, we can see a thrombus causing this occlusion. Now, the atherosclerosis obviously is dependent on hyperlipidemia, hypertension, diabetes, and smoking, and other lifestyle choices. So, how about this atherosclerotic plaque? Let's talk about it a little bit. First of all, we can see that there is in the center, the necrotic center, right? The inner region of the atherosclerotic plaque, which is composed out of cell debris, cholesterol crystals, and foam cells and calcium. The outer region, the fibrous cap, which is more elastic, has smooth muscle cells, macrophages, and foam cells, lymphocytes, collagen, and proteoglycans. We usually differentiate between two forms of atherosclerotic plaques. First of all, one being stable, with a thick fibrous cap and usually being associated with calcification, or we can see unstable plaques, which have a big fatty core and can easily rupture, ulcerate, or cause hemorrhage, which all will lead to thrombus. The complications. 90% of them are symptomatic, and pretty much all of myocardial infarction is related to thrombi. First of all, being arrhythmia, cardiogenic shock, left-sided heart failure, where in the acute case we see pulmonary edema, and in the chronic case we see brown induration of the lungs, cardiac rupture, which appears in 3 to 7 days, or some sources say 3 to 14 days, which will then lead to cardiac tamponade, which is the disease in which the sac around the heart fills with fluid, acute right-sided heart failure, and acute mitral insufficiency. Next up, we can see fibrinous pericarditis, parietal thrombus, which can also become an emboli, aneurysm, and occlusion of the coronary artery by a thrombus emboli or inflammation. Other diseases also include the Kawasaki disease, the vasospasms, and a higher myocardial demand for O2, and hypertrophy of the myocardium. Now, onto the places and the color, basically the classification of it. It can be either subendocardial, as you see here in this picture, where we can see that it's only affecting the endocardium and the inner 1/3 of the myocardium, and in the ECG we see NSTEMI, meaning no characteristic one. Where in the second case, where it's transmural myocardial infarction, we can see that it's in all three of the histological layers of the heart, meaning the endocardium, the myocardium, and the pericardium, and we can see epicardial occlusion and the formation of thrombus. In this case, because it basically involves all three of them in the transmural case of infarction, we see STEMIs, meaning a clear ECG sign and the prominent ST segment, which is elevated, which always leads to myocardial infarction diagnosis. Now, for the other types, we usually say red infarction, which is associated or named hemorrhagic, and this occurs usually in more loose tissue like lungs and the GI tract, for example, and these are the result of venous occlusions. Whereas in the second case, we see white infarctions, anemic ones, which are located in more dense tissue like the heart, kidney, spleen, and the other organs, and most of the other organs, and they result of arterial occlusion in the opposite. The diagnosis, the main ones being troponin or troponin I and T. They will rise within 2 to 4 hours, and they will peak at 48 hours and then from there on slowly decline. Whereas the kind of faster option would be CK, or creatine kinase, which also rises in the 2 to 4 hours, but it will already peak at 24 hours and decline down by 48 hours. So we can see that by the time creatine kinase will decline, troponin will have just peaked, meaning creatine kinase is the faster one out of both markers. And here we can see a beautiful picture which basically summarizes the stages up from 0 to 24 hours, 1 to 3 days, 3 days to 2 weeks, and after 2 weeks. And as we can see here, arrhythmias, cardiogenic shock in the first 1 day, then obviously the pericarditis as the inflamed tissue gets invaded by neutrophils. In this case, as I already told you, it's at risk for a rupture, and as a healing process you will see granulation tissue, which is in this case the macrophages, and after that we are still at risk for heart failure, and ultimately there will be a scar inevitably, and that is myocardial infarction. Thank you.